Okay, so let's continue on with shocks and talk about our distributive shocks. And the three types of distributive shocks are anaphylaxis, septic, and neurogenic. So what happens in distributive shock is we have widespread vasodilation. So your peripheral vasculature dilates. So I have a decreased SVR, but your blood volume is unchanged. So that's called relative hypovolemia. And that's like your tank being half full. So we did discuss this in our sim about what this looks like. So we have to think about the fact that we've got this relative hypovolemia and decreased SVR for these types of patients. Because of this widespread vasodilation, we do also have decreased return of venous blood to the heart, which is our CVP, and certainly decreased cardiac output, index blood pressure, and poor tissue perfusion, cellular metabolism. All right, so let's jump into anaphylactic shock. I know you studied anaphylaxis last semester and probably talked a little bit about how to prevent or treat the early stages of anaphylactic shock. So this is a severe allergic reaction. We have this antigen antibody response, which releases histamine, which is a widespread vasodilator. And all of this means decreased blood pressure and relative hypovolemia. So, what causes anaphylactic shock? Foods, namely nuts are probably your most common, and shellfish. Can be other things. Medications, so think of things like ACE inhibitors with the potential for angioedema, so swelling of my face, lips, tongue, which means I'm going to lose an airway. Fundamentally, anaphylaxis is all about A and B, because that's the problem, which will lead to C, airway, breathing, circulation. And then insect bites like bee stings, wasp stings, those types of things. So how do they, what clinical manifestations do they have? Well, they have flushing, itching. They can have angioedema. They may have hives, tachycardia with hypotension. They'll be tachypnic as well. They can have upper airway obstruction, so the cough, hoarse, trouble speaking, stridor, that high-pitched wheezing, lower airways, certainly wheezing, chest tightness. This is all about airway. So we want to, first thing is certainly get an IV on these people. Remove any offending agent. So if they've got a bee sting, they've got the stinger in them, we need to take that out. If it's from medication, like you gave them an antibiotic and they are starting to have an anaphylactic reaction, then you stop that antibiotic. You stop the blood transfusion. We can, if it's something that they ingested, we could do a stomach lavage. We want to give them medication, and fundamentally the first line thing we're going to do is actually give them epinephrine. Epinephrine is going to vasoconstrict them, so I have more blood pressure, offset that vasodilation going on, and it's a bronchodilator, so it's going to help them breathe better. So your number one medication is epinephrine. We're going to put some oxygen on them. We need to give them fluids, normal saline or LR, to fill that tank. We may give them antihistamines. We can also give them H2 blockers, like ranitidine or Tagamet. I always cannot ever remember the generic name for that. We could give them corticosteroids, and if we needed to, we would do inotropes and vasopressors to help. Probably start with vasopressor first to offset that widespread vasodilation. But your number one thing is to give them epinephrine. You worry about an airway. We may need to intubate these patients if we want to do that early before we have total constriction, because if they close off their airway, we cannot get an ET tube in them, and we would have to do an emergency trach or have difficulty doing that. Anaphylaxis can go on so severely, actually happens very quickly, that we are not oxygenating them, and they will have an anoxic brain injury, and they can die from that. So this is so important. If people know that they have anaphylaxis, they need to carry an EpiPen. And that is to things like insect bites, foods, things that they may become in contact with that they don't know. If you are allergic to an antibiotic, you do not need an EpiPen. You need to tell people what you're allergic to, and you should not be given that antibiotic, so they wouldn't need to carry an EpiPen for that. Which means if you were going to give somebody an antibiotic, before you push start on that pump, you should make sure what their allergies are. Now, can people have an anaphylactic reaction from an antibiotic and never know it? Never know that that was something they were going to be having a reaction to? Yes, which means we need to monitor them for signs and symptoms. The other thing is also, this could happen from a blood transfusion. So part of what we would do is stop the antibiotic if that's the cause, stop the blood transfusions, give them fluids through different lines to take care of that. And we could lastly do stomach lavage if it's something that they ate. Okay, so let's talk about neurogenic shock. People who have neurogenic shock are patients who have had a spinal cord injury at T6 or above. If it's below T6, they are not going to have neurogenic shock. This is temporary loss of autonomic function below the level of the injury. This occurs in the hospital setting. They will not have this long term. Long-term injuries and problems from neurogenic shock is autonomic dysreflexia, and we have to teach and tell them how to prevent it and treat it if they have it. Neurogenic shock is something that's going to happen in the hospital and probably in the setting of the ICU. So what happens is the brain stem is trying to send this response, but the signals can't get through to the vessels, and we have massive vasodilation. So we have decreased SVR, decreased venous return to the heart, decreased preload, decreased cardiac output, and that relative hypovolemia. The two biggest things that they have is bradycardia and hypotension. Somebody with a spinal cord injury who has bradycardia, that's a bad sign. Fundamentally, bradycardia in a neuro patient, a traumatic brain injured patient, bradycardia is always a bad sign. And they have hypotension. The other causes they could have this from is spinal anesthesia and some type of neurosystem damage. So clinical manifestations: bradycardia, hypotension, warm, dry, flushed skin. That blood is out in the vessels, out in the periphery, which is why it's warm and dry. They can have some hypothermia due to impaired thermoregulation. They're going to have venous pooling in their extremities, so warm and dry. And our treatments are to give them fluids. We give them atropine for their symptomatic hypotension and the bradycardia, and we need to maintain their blood pressure, which means we may do dopamine that will help increase their heart rate. And we could give them things like norepinephrine, and if they become hypothermic, we would need to rewarm them. So fluids, atropine to increase heart rate, which will help with that bradycardia, and we may need to give them vasopressors to maintain that blood pressure. So patients can be in and out of this. I've seen this with spinal cord patients. They start to have some neurogenic shock. We give them some atropine. We get that heart rate back up. I would worry about these people if they were less than 60. Certainly they're going to be symptomatic less than 50 in the 40s, and so we treat them off and on all day. So neurogenic shock is spinal cord injuries at T6 and above. Okay, so I think what I'm going to do is stop our recording and because we're ready to go to septic shock and leave that one to be its own recording. Thank you.